prostate cancer imaging and theranostics. So let's talk about specifically radioactive imaging, nuclear imaging, or radiotheranostics or nuclear theranostics technique that are using radioactive tracer, radioactive drugs. So for imaging, it's about the target. PSMA has been shown and found to be a very, very relevant target for prostate cancer imaging and treatment. So I think it will still be used for decades now, in the maybe next 2 decades, for both imaging and treatment. Probably more sensitive agents will come to the market with, I don't know, slightly different biodistribution properties. So you will have small improvements of the already very good performances of this diagnostic PET tracer targeting PSMA. But now we are in the PSMA target era. Maybe one day another target, even more relevant for prostate cancer, will come up, and you will have some dedicated radioactive tracer that can go to this new target. There may be other that will come one day. But currently, this is PSMA, very relevant. Why? Because highly and specifically overexpressed by the prostate cancer cells, whereas you have a, let's say, low background activity in most of the normal organs around. So high tumor uptake, low normal uptake. And that's what you want for imaging and theranostics. And so maybe in one day you will have a better target with even higher tumor uptake and even lower background uptake, salivary gland, for example, kidney, for example, other organs. And so maybe that will be a future target. So that can be something you can envisage for the future. In a more short term, I think in the PSMA era, maybe new tracers will come with slightly improvements, but I think it's still in the same range of performances. You may have slight improvements as possible. So PSMA 11 is the mostly used one now. Then you will have DCF-PYL, you have RH PSMA, you will have maybe PSMA 1007 and maybe others. And let's see how it goes. But basically, they are more or less all in the same range of performances. So this was for the diagnostic imaging part. Now we should talk about the theranostics, or maybe more the therapeutic aspect of PSMA. So you have this companion concept where you have a test that can detect if the patient expresses a specific target, in that case, PSMA for prostate cancer. You assess it with imaging, PET imaging, and then you can change the radioisotope that you use from a PET radioisotope, PET imaging radioisotope, to a treatment radioisotope, such as lutetium, such as actinium, such as thorium, such as yttrium. There are others. The most currently used one is lutetium, of course, for many reasons that I will not go here over. And here again, I think how we can envisage the future. I think more and more agents pushed by the kind of industry and academic research will come up on the market or will become available that target, again, this very relevant target for prostate cancer disease, PSMA. And you will have it with different radioisotope, with different molecules, but basically it's the same concept. You target these cells that have high overexpression of this PSMA with a radioactive agent. You assess disease expression with imaging, then you give molecular radiotherapy agents. So this is the current concept. So how can it evolve in the future? Again, you can refine a little bit the treatment dose, activity level you can give, the time interval between each cycles, how to better select patients who are more likely to respond or not. Maybe have some way to decrease the radioactive drug uptake in normal organs to decrease the toxicity. It will be kind of the refinement of this PSMA targeted molecular radiotherapy era. Now, the future will be, again, another target, even more specific for prostate cancer without this low background uptake, without any background uptake in normal organs, allowing for high dose molecular radiotherapy with less toxicity. So maybe other targets will come up in the future, and I think that's where it will go. Always keeping in mind that the theranostics concept is a tumor to background ratio. You can see right away on an image if your treatment will work or not. If you have high uptake in tumor lesions, low uptake in background organs, it's very likely your treatment may work, very specific, targeted treatment. And I think that's the beauty of the theranostic concept. You can see it on image. You look for high tumor to background images and disease, and then you can give this targeted molecular radiotherapy treatment. And I hope that new targets will emerge and that refinement of all this will continue to be able to offer that to patients in prostate cancer, but also in many other cancers.